We will be discussing in detail about Carotico cavernous fistulas in this lecture. So, first, let us look at the headings in which we will be discussing this talk. We'll define what CCF is. We'll understand the anatomy of the cavernous sinus. Then we'll go into etiology and the classification of CCF. Then once we understand the pathophysiology, then it will be easy for us to understand the symptoms. Then how do we evaluate a patient with a CCF? What are the treatments and the indications for treatment? What is the post-treatment follow-up? And what is the conclusion? Now, how do we define CCF? So technically, Carotico cavernous fistula is an abnormal communication that exists between the cavernous sinus and the carotid system. So we know that the cavernous sinus surrounds the carotid artery in the segment just before it becomes intracranial, and thus any injury to the carotid artery here will induce a direct communication. And also we know that there are dural fistulas also which can arise in this region. So like we said, it can be a direct connection between the cavernous segment of the internal carotid artery and the cavernous sinus, or it could be a communication between the cavernous sinus and one or more of the meningeal branches of the internal carotid artery or the external carotid artery, or both. Now, the first description of a pulsating exophthalmos was done as far as 1830. And you can see the picture out here, very, very typical of a CCF that you would see after trauma, where there is exophthalmos and there is chemosis. But to truly understand about CCF, one has to have a clear idea about the cavernous sinus and its anatomy. So the cavernous sinus is basically in the middle cranial fossa by the side of the sella as it goes inferiorly. And I will talk to you soon about the communication that exists. But remember, the cavernous sinus, though is typically considered to be on both sides of the carotid artery, it actually extends all across with multiple bridging vessels that are there. Now, if this is the cavernous sinus, it gets its supply both from the forehead and from the face through the superior and the inferior ophthalmic veins. Then it also gets blood from the sphenoparietal or the pterygoid plexus, which arises more from the region of the maxilla. And then we also get flow coming from the middle cerebral vein. Now the outflow is through the superior and inferior petrosal veins, which go posteriorly over the petrous bone. And finally, this would go and communicate with the transverse sinus. So once again, to understand, the inflow is from the superior and inferior ophthalmic veins, the middle cerebral vein, and the pterygoid plexus, and the outflow is from the superior and inferior petrosal vein. In addition to that, we have got communication which will exist between the two cavernous sinus. Now, why does the cavernous sinus produce such a lot of neurological problems? And that is because of the several cranial nerves that are there along the lateral wall of the cavernous sinus. So this is the cavernous sinus. We got the oculomotor nerve here, the trochlear nerve, the ophthalmic nerve, the abducens nerve, the maxillary nerve. So we get this thing that all these nerves can get involved when there is increased pressure in the cavernous sinus. So you can have ptosis, you can have lateral palsy, you can have the superior oblique muscle getting involved. Along with that, when the venous outflow gets obstructed, you'll start having chemosis. Now the symptoms of CCF will depend whether it's a direct or an indirect CCF. So what is direct? Direct is the one with a large rent that is present between the carotid artery and the cavernous sinus, and the indirect ones are fistula which arises from the meningeal vessels that arise from the external carotid artery, like from the distal branches of the internal maxillary or from the branches that arise from the carotid artery direct. Also, the nature of evolution can be very, very different. What do you mean by very different? It would basically mean that you can have somebody with a direct fistula which will never get settled unless we treat, whereas you can have a slow flow fistula which can get disappear even without treatment at times. And then, of course, we've got a condition which is called the white eye syndrome, where the patient is absolutely blind and he comes to you and you may not even be suspecting CCF at all. Now, this is a classification which we used most commonly called the Barrow's classification. A is the direct fistula. It's commonly traumatic, or it's because of rupture of an aneurysm in the cavernous segment of the internal carotid artery. These are the real high flow ones. Then type B is technically a much slower flow fistula. These are multiple branches which arise from the internal carotid artery. C is multiple fistula arising from the external carotid artery. And type D are multiple fistula which can be a combination of the internal and the external carotid artery. Okay. And the etiology of direct is commonly it is a trauma, and sometimes it can be an aneurysm that's ruptured, and these can be secondary to a condition like fibromuscular dysplasia or Ehlers-Danlos. Any of these, or a spontaneous dissection also can sometimes rupture. Whereas the indirect ones are between the dural branches of the internal or the external carotid artery and the cavernous sinus. They can happen in pregnancy, secondary to sinusitis, can also be traumatic, and which induces thrombosis of cavernous sinus. But most of it, you understand, is secondary to partial thrombosis of the cavernous sinus, unlike the direct ones, which are more because of an aneurysm or trauma. So let's understand this classification a little better. The red is the carotid artery, the large blue elliptical structure is the cavernous sinus, and all the others are the veins which I talked about earlier. In a direct fistula, you get this jet of blood that will fill up the cavernous sinus and induces an increase in pressure associated with pulsation of all the veins. So now the flow which was supposed to go toward the cavernous sinus is reversed. So the superior ophthalmic vein usually becomes large, gets tortuous, increases severe venous pressure because the drainage is reversed, inducing severe chemosis, proptosis, and the whole eye starts pulsating because the flow in the cavernous sinus is now arterialized and has actually got systemic pressures and transmit the pressure from the artery into the cavernous sinus. Also, along with that, the petrosal sinus starts filling, and then you can also have engorgement of the pterygoid plexus and also the middle cerebral vein. Now, the middle cerebral vein, when it starts opacifying, it's dangerous. Till that point of time, even if treatment is delayed, the maximum you'll have is visual problems. But once the middle cerebral vein is opacified, it can be lethal because this can induce bleeding secondary to a rupture. So this is how typically a type A will present, chemosis, a swollen eye, which is pulsatile. But when we come into type B, C, and D, these are basically vessels which communicate between the cavernous sinus and the internal carotid artery, or vessels from the external carotid artery, or a combination of both. Now, what happens here is a very different picture. The cavernous sinus gets oxygenated blood, but the pressure builds up based on the outflow, but it doesn't pulsate like what you expect with a high flow fistula. We have to understand the key difference in symptoms. So now let's see what are the associated problems that we have with these. At times we have a situation like this where the superior and the inferior ophthalmic vein is thrombosed, so is the petrosal veins, so is the veins that go into the pterygoid plexus and the middle vein. So what you have is a sequestered cavernous sinus which bulges up, and there are some small tributaries that seem to extend. Now these will present this way. Since the ophthalmic vein is not filling, you may not see redness, and since there is increased in pressure and engorgement and dilatation of the cavernous sinus, they often present with cranial nerve palsies and very commonly a lateral rectus palsy. So remember, an isolated lateral rectus palsy, it always requires further investigation in the form of an MR or at least a CT to ensure that we rule out pathologies, especially those which involve the orbital fissures or CCF like this. Now let's look at another type. Now in this case, all you may have is an outflow through the middle cerebral vein, and it's obvious that this is even more dangerous because they often present with a bleed. And when they come to a bleed, and you may actually find a CCF and needs immediate treatment. Or for example, if you have a situation like this, where the only veins are the superior and inferior ophthalmic vein, they will not dilate like in a direct fistula, but yet they will give rise to redness of the eye. Chemosis may not be very prominent, but you can understand how the pathology, how the symptoms keep changing depending on the outflow. Or for example, look at a situation where you may have just a petrosal sinus filling, where sometimes all you see may be just a mild redness and nothing else. So like we said, the symptoms are decided whether it's a direct or indirect, the size of the fistula, the duration of the fistula, and the adequacy of the venous outflows, and the classical Dandy's triad, exophthalmos, bruit, conjunctival chemosis, is primarily for a direct fistula, and thus you must understand that when we call CCF, it could, and very often this is just a diagnosis we'll make on CT and MR. Do not feel carried away and say, look, I'm not seeing chemosis, I'm not seeing a pulsatile exophthalmos, how can the CT or the MR make a diagnosis? What they're talking about is a slow flow fistula where the symptoms can be very, very different. And like I talked, there's increased pressure in the orbital veins, so there's transudation of interstitial fluid, proptosis, exposure keratitis, increased intraocular pressure leads to glaucoma, and these all can end up with decreased perfusion, decreased vision, intracranial hemorrhage, cranial nerve palsy, and at times permanent blindness. And sometimes you know that you can also rarely get varices into the nose from the pterygoid plexus, and they can also present with epistaxis. So how do you evaluate a patient? Technically, when you see a finding, you can ask for a CT, an MR, and after that go for a DSA. Now this is a finding that you'll see in CT. What do you see? You see the cavernous sinuses. They are really engorged, which should not be seen. The superior ophthalmic veins are dilated and prominent, and you can be certain that this is a CCF. Of course, if it's a type 1 CCF here, you can also see the exophthalmos present over here. So all of this, you can be sure it is a diagnosis of a CCF. But sometimes we can have an MR where you may not see a lot except something like this, edema of the fat on both sides with a prominent cavernous sinus. That may be the only finding that you may see at time. Now the problem of cross-sectional imaging is, or you cannot end with cross-sectional imaging because it doesn't have temporal resolution. It doesn't tell us the feeders. It cannot tell you whether it's from the ECA, the ICA. It cannot classify the dural CCF and tell us whether it's a direct, whether it's an indirect, whether the outflow is blocked or whether it's sequestered. So to understand this towards treatment, it's mandatory that we do DSA. Now DSA, not only does it confirm, it shows the size and location of the fistula. It shows whether it's a direct or an indirect and further subclassifies. It is able to show the high-risk feature, whether it's going to bleed or not. Since it shows the venous drainage patterns, we can also plan the therapeutic route, whether it's a venous approach or the arterial approach. We can also look and see the carotid bifurcation. We may sometimes compress it. And we may also do a balloon test occlusion in the same time if it's a badly damaged distal ICA and where you know it's completely amputated, and we have to now think about whether we're going to sacrifice the vessel or not. So having understood this, let's talk about the treatment options that are currently available for CCF. So one is conservative. What's conservative? You have a patient who comes to the slow flow dural AV fistula or CCF, And we also realize that the access is very difficult. We don't have a proper draining vein, we don't have an arterial access, and it's slow flow. So we can do a conservative therapy in the form of carotid compression, or we can also send the patient for SRS, stereotactic radiosurgery. Then we got the endovascular. When there is a definite access, you can do transarterial, especially in the arterial, in the direct fistulas, and transvenous for the indirect fistulas. And theoretically, there's a surgical option which technically doesn't exist. And instead of surgery, it's much better to consider SRS or stereotactic radiosurgery as an option, not a direct surgery, where we have been seeing pretty good results in indirect fistulas. Now, when we talk about a patient for conservative management, you've got a patient who doesn't have an access, has got a very slow filling or a slow flow CCF, then what would you do? So this is basically what you would do. You'd ask the patient to place his thumb on the angle of the mandible on the same side. That means he uses his right hand, he puts his thumb on the angle of the mandible on the right side and uses three of his fingers, that is digit 2, 3 and 4, and asks him to feel the pulsation of the carotid artery under the angle of the mandible and compress it really hard. And they hold on for that for 10 seconds. Repeat this maneuver 10 times. That is, he holds for 10 seconds, gives a gap for 10 seconds, holds for 10 seconds 10 times, and do that at least 3 times a day on both sides. Though it looks like a strange or a ridiculous exercise, but you will be surprised to see that in many, many slow flow fistulas, this can actually be curative. The patient will come back to you a month or 6 weeks later, and you'll find the CCF has completely disappeared. So when we've got patients who've got a definite, decent draining veins which you can access, or in a patient who has a direct fistula, in direct fistula you will not subject them for conservative treatment, it will never work. But in the other group, we have to plan for an endovascular treatment. So here is a patient who's got a post-traumatic CCF. Clinically, the patient presents like this. He's got hypophthalmos, chemosis, ptosis, and we now take a detachable balloon or an occlusive device, either balloons or coils, and we block the fistula off, and you will find a remarkable change. Within 24 hours, the patient will have a remarkable change, and that is the most gratifying thing of CCF. For example, have a look at this. There's a patient, it's a direct fistula. See the large dilated superior ophthalmic vein. Posteriorly, the petrosal veins are filling up. You put a single detachable balloon, and it's a curative procedure. On the other hand, here is a patient where there's a disruption of the ICA. Free filling of the superior ophthalmic vein, free filling of the petrosal sinuses in the back, free filling of the pterygoid plexus inferiorly. We enter this, we coil it, we take the parent artery off, and it's a curative treatment. He came this way, and within 24 hours, he would be looking something like this. It's very, very remarkable. You can see the delay is not much. You can still the bruising out here, which is still not gone, and he has done so well. Here is another patient. Again, you've got a CCF. This is an injection from the opposite side. This is the lateral. And for some time, we had been doing this, which we have stopped now because we have not been able to get these devices called the stent graft. So stent grafts are basically stents on which there is a fabric mounted. So this is the stent graft across this. This is the material. And this is the result after this. Very, very rewarding result, especially in young people where the cavernous sinus is not very tight. And we actually published the results of this where we had 100% success in several of the patients we treated. So that's how we will manage a direct fistula, where we said we can either put coils or we can put a balloon or we can sacrifice the artery or put a stent graft. But the most important thing to understand is that all of them can be treated. And because there is a big rent, it's technically not challenging to treat it. Now let's come to the slow fistulas, which is B, C, and D. Now these are technically a lot more challenging. Believe me, it's a lot more difficult, can be very, very difficult at times to treat it. And I will talk about that in much greater detail. So I said the B is from the ICA, the C is from the ECA and the D is from both, and most of the time what you see is a D. But look at this patient. This is a type C, an isolated fistula coming only from the ECA. You can see this ECA injection. You can see a terminal branch of the middle meningeal giving this fistula out here. We actually enter this with a microcatheter. We put a drop of glue, we occlude it, and it's a curative treatment. And see, it's completely gone. Instead of that, let's see this young boy. He came to me nearly 20 years ago. He's got redness is why for 3 months, proptosis for 3 months, normal vision. He gives some history of minor trauma which has no relevance at all. We do an angiogram and you can see from the ICA the cavernous sinus is filling, from the ECA the cavernous sinus is filling. You can see the intercavernous communications this side. It's important to see that on the ipsilateral side there is no filling. So we understand the access has to come from the opposite side and it has to be a venous approach. Look at this. It's pretty big when you take an injection in the common carotid artery. So this basically is the treatment that we offer. What we need to do is we enter from the jugular vein, enter to the petrosal sinus, enter into the sac, fill the sac with coils. And once you fill the sac with coils, and after a couple of months, it will automatically shrink and it's a curative treatment. Here is it. We have come from the jugular vein on the opposite side. We crossed the midline, came to the opposite cavernous sinus. This is within the sac. This is after we coiled the sac. This is the angiogram after that in the early and delayed phase, showing an absolutely perfect cure. This is the young boy a few days later. Today he's a college student, looks totally normal, no symptoms whatsoever. But just want to tell you how remarkable these treatments are and how much of transformation it can offer to a child who can come pretty sick. Have a look at this, a bilateral type D CCF. Type D basically means he's got involvement with ECA and ICA. All he has got is some lateral rectus palsy. You can have a look at this. And we do an MRI. All we see is prominent cavernous sinus on both sides. The same thing. Now we do a right carotid injection. Look at that. It fills the cavernous sinus from one side to the other side in the arterial phase. Lateral, same thing seen. You can see the cavernous and the petrosal sinus filling over here. This is from the opposite side. This is the ascending pharyngeal. And this is the left internal carotid injection. Basically, you see that both sides supply to the cavernous sinus. Same thing. This is the middle, the internal maxillary artery. Similar finding from the ipsilateral side. In the lateral view, similar findings. So what do? We enter from the jugular vein, enter into the petrosal vein, enter into the cavernous sinus, and we do a treatment that looks crazy. Honestly, it's scary if you think of it, because you wonder how does this work? But the truth is it works all the time. It works all the time in the sense like here what we're doing is technically we are actually entering the sinus, and you see we have actually filled up both the cavernous sinuses. And one may say, then how doesn't the patient have a problem? Because the pressure was so high, the flow was being reversed as such, so it was technically no longer contributing in any way to the normal cerebral venous supply, and so there is this huge difference. Now see this, an absolute cure. Have a look at it. No filling of the cavernous sinus in the arterial phase from both sides. We'll take an injection on the opposite side also. It's a complete cure done by entering. And this is the ascending pharyngeal. See, everything goes by just taking the cavernous sinus away. We don't really have to go to the artery and block, and that is not the way of treating it. It is basically accessing the cavernous sinus and going through that. And sometimes it can get even more technically challenging because access may be very difficult. We may not be having the veins that we want. And here is a patient who came. He's a 34-year-old guy who's come with diplopia, conjunctival chemosis, secondary to lateral rectus palsy, and he's got a history of some mild trauma 1 year back. So you can see the chemosis over here. You can see the lateral rectus palsy. His eye is not able to move. We do an angiogram, and what do we see? You can see just filling up of the superior ophthalmic vein alone here and the facial vein alone here, nothing else. Most of it has been thrombosed. There is no outflow posteriorly. Have a look at it. The only vein filling cavernous sinus and a direct exit onto the superior ophthalmic and then the facial vein. So in this case, the only access that you can have will be through the facial vein. So this is the AP showing the same picture. So this is technically what we find: injection, cavernous sinus fills, superior ophthalmic vein, and from there it comes down facial here. ECA, very similar findings. So the plan is to go this way, go from the femoral, enter the jugular, enter into that, go into the facial vein and cannulate. So you can see this is the catheter. This catheter is in the jugular vein. From here we enter the facial vein. You can see the catheter coming all the way, entering through the superior ophthalmic vein and entering the cavernous sinus. It's a little more tricky, obviously, but it works, and it works very successfully. As you can see over here, we have completely embolized the cavernous sinus. Okay? And it's a curative treatment as usual. No filling at all. And see, pre-procedure, post-procedure, patient comes 1 month later, absolute normal movement of his eye. Sometimes we can get something even more crazy when there are no outlets at all and the patient will again present with cranial nerve palsy. So this was the MR and then the angio. Have a look at the angio. You can see the cavernous sinus opacifying here. See this in the lateral. All you see is this and the middle cerebral vein filling here. Obviously, we cannot catheterize the middle cerebral vein, so we have no outflow. So in this case, we have to locate the thrombosed inferior petrosal or the superior petrosal and drill our way through it and enter into the sinus. So this is the jugular. So this is where we expect the petrosal sinus to come like this. And this is what we have done. We have actually drilled our way, entered the cavernous sinus, and then we coil the cavernous sinus, and here it's a curative procedure. So technically, I hope you kind of understood the whole idea about CCF. That CCF is not just the direct large fistulas, you can have the large and the small. The symptoms would depend a lot whether it's large, whether it's small, slow, if it is slow, what kind of outflow we have. But we also realize that all of them can be treated, either from the arterial route or from the venous route. And finally, if none of that work, we can always subject them for stereotactic radiosurgery because those will be really small fistulas. So CCF can be direct. You can have pulsatile exophthalmos bruit and chemosis for direct CCFs. CT and MR can often give us a diagnosis. Manual compression with carotico jugular fistula can help us for a slow flow fistula. Endovascular treatment can definitely be the solution for a large number of cases, and the rare ones can always be treated